Hello everyone. One, two, three. Anyway, not many. We haven't got many people yet. I hope they come in the door because there's a bloody lot of food over in that kitchen that we've all got to eat. And it doesn't matter, just the fact that all you guys are here. And we've done our best with advertising and getting it out there. It's been on. There's 20 notices around town. So, you know, what do you do? If they don't come, they don't come. But they might, yeah. Anyway, in the meantime, welcome everyone and thank you for coming along to the third Esperance Dying to Know Expo. The original idea for the Expo came after we'd had one of our Death Cafe meetings in the little lounge room here, and the issue of dementia had come up. So after we'd cleaned up and we were ready to leave, Meredith Waters and I were sort of saying, oh, we need to get, everybody in the community needs to know about dementia. You know, it's out there, it's infiltrating our whole, so many families and the whole community. We need to be switched on about this disease that impacts people. So we sort of looked around and thought, oh, this is actually a good place to do something like this. And a few days later, and the thoughts went around in my head, and then Heather reminded me that we had a Seniors Expo many years ago that Esperance Home Care ran, and that was a real success. So we thought, okay, let's just make a plan and do it here. So the Senior Citizens Centre, with Sally at the head back then, said, yeah, let's give it a try. And the first year was COVID because we all had to wear masks, and 2 days prior to that, Ukraine had been invaded. So we were just all sort of in a little bit of shock, really, I guess. But anyway, it was very successful. Last year it was successful as well. Both of those 2 times we've had about 120 people come in. So anyway, that's where it came from. But I just want to explain a little bit about the Death Cafe. And thankfully, talking about death and dying, it's becoming a bit more accepted. And I'm sure that that's a little bit to do with all the death cafes that get held around the world. In 89 countries now, there's thousands of them. I think I've got a figure here somewhere. No, I haven't. Anyway, ours is just one of thousands of groups that get together once a month, and we talk about the realities of what happens. Not only for the death process, but as you get to that, you know, aged care, we talk about lifestyle villages, we talk about what are we going to do with all our things when we finish with them, who's going to have them, we talk about wills and donating organs and everything. So when we come, because there's no agenda, when you sign up to be a facilitator, part of the guidelines is that you don't have an agenda. So we never know what we're going to be talking about. And sometimes it's very interesting, isn't it, all you Death Cafe people, who is most of them here. So it's really great. It makes it more open. We can go home and talk to our families, and it just brings it out from under the table. So that's what today's about as well. Everybody who comes will gain information from all of you guys. Hear knowledge that you might not know, but also making connections. Have a cup of tea, talk to the people that you haven't seen for a long time. For somebody who's not supposed to talk for 6 weeks, I'm going to be doing a good job. If you're interested in the Death Cafe, there's going to be people over on the table throughout the day. So just go up and just put your name down on the list there, just with your name and phone number. I'll get in touch with you and let you know when the next one is going to be. And just go and have a look at the table and see what we do. I'd just like to thank some people first before we go, before we start. Not before we go, before we start. Did anyone come along to the Esperance funeral services last night? I can see a few faces. Pat, yeah, the girls up the back, Betty. Heather and Kevin opened their doors out at Esperance Funeral Services. It was fantastic, wasn't it? We had a little memorial service, then we had wine for those of us who were brave enough to have some, and nibblies, and in 2 separate groups, Heather and Kevin took everybody on a tour of the facility, and everybody was just blown away. It was great. And they've been trying to do that for a long time, and every now and again say to people, come out, because it's a very scary place when you've got to go out there and you're grieving, to have to sort of But if you know what the building's like, it's not scary. It's just a building, you know. So anyway, that was lovely. Thanks very much, guys, for doing that. A big thank you to Cheryl, of course, who's not here at the moment, but Amanda is. To Sally and all the senior citizens members who, again, with enthusiasm, welcome us here to this fantastic venue. They've got homemade food for us throughout the day, and Sally's going to tell you a little bit about the seniors. Oh, thanks, Kathy. She can see I'm struggling. A huge thank you to Joe Ramsell, Erica Austin, Louise Molyneux and Jane Wells from Dementia Australia for sharing your expertise and valuable weekend time for us today. Sadly, Meredith Waters, who you all know, has had to go to Melbourne, so she can't be here. Steph and Cody from the Kalgoorlie Community Legal Service, who I met the other night at their session down at Boyko. I just sort of said to Steph, look, we've got somebody who's not here. Would you be willing to talk a little bit about wills? She said, yeah. So she's filling in for Meredith, which is fantastic. Thank you to everyone who has helped set up or are volunteering on a table here today, and the doors. Thanks, girls, and all of you who have come to bring and share information to encourage us all to learn about how to make the most of our lives. Without you all, we couldn't have this expo. Oh, and I haven't finished yet, sorry. As you came in the door and were greeted by our lovely girls on the door, you would have been given a coloured folder. These are much better than calico bags. Sorry, girls up there with your bags, but I go to so many places and bags don't hold things nice and flat. You get home and everything's in the bottom like this. So we've done these folders since the first year and they're great. Sally's even bought hers back from last year. So she's doing really what I want to do. Use it to collect all the information. Now this year we've put a couple of sheets of note paper in there for you to use, and there's more note paper up the back near those posters. There's also some feedback sheets on the tables up near Denise on that entrance table. There's some feedback sheets. Please just let us know your thoughts before you leave. And there's a workshop this afternoon on writing your own life story. So if you're interested in doing that, just pop your name down on a bit of paper over at the Death Cafe table, or let me know, because I'd just like to know how many people are going to be here. I wanted to talk a little bit about grief today, not long and extended, but just how it affects all of us at some time of our life. Whether you've been through grief even recently, or whether a long time ago, we will suffer with grief. It's just a part of our lives. But today, with so much going on in the world, without even considering what's going on in our own lives, there seems to be feelings of anxiety, uncertainty, of loss, and a certain amount of grief to be faced every day. We are confronted by events happening everywhere which we would never have thought possible. We must give some of our own time just to hold space in our hearts for the whole situation, whether it be humans or nature that is suffering, because we are all here together as citizens on this unique planet. We can, of course, donate to or volunteer to any of the organisations doing their best to help on the issues which bring those feelings to the surface for us. But also, as a way of counteracting some of that overwhelming distress, it is to constantly remind ourselves how lucky we are. Lucky to live in this Esperance paradise, an isolated area of the planet surrounded by extraordinary natural beauty. We are lucky to have freedom most people around the world do not have. We're lucky not to be living in a war zone or a place of incredible hardship, trying to keep our children alive. Up the back on the glass doors are two display boards, grief and gratitude. During the day, I'd like you to, there's plenty of paper there and there's biros and sticky tape. Please take the time, if you're okay to do that, to just write up what you're, not necessarily the loss of somebody, but just what you feel sad about, the future. I know a lot of people with grandchildren are concerned about their future. What's concerning you, but also what you have gratitude for. And just during the day, if we get enough of those up there, if enough people contribute throughout the day, I might try to put them together into a little booklet for next year, because what you might put up there might be what other people are thinking as well. You know, there's a general awareness now of, oh, we're going down the chute. So we just want to bring that out and let people express that. You can put your name on it if you want, but you don't have to do that. Also today we have Amanda Green. She's going to professionally record the session so that later on others who couldn't be here will be able to access to see them. I will be sharing them to the Esperance Death Cafe Facebook page and a link to all the Death Cafe email group, of which there are 115. Where are you guys? Thank you, Amanda. We do try to keep to time, but there are 15-minute breaks between each session, allowing you to get up, grab a cuppa, stretch or look at the information. I may have to use my little bell if we need to get started and there is background noise. I'm sorry, I don't think there'll be much at the moment. Please make the most of the opportunity to ask questions. We have another microphone this year as well, so everybody can hear, because the question you ask might be what other people would have wanted to ask. Finally, if you're not comfortable in the seat you're in but you need to be close, please swap it. Pitch them from over there if you want those nice comfy chairs, just to make sure you're comfortable. And when that's done, if anyone wants to move, Sally Ashville is going to come and fill you in on the Senior Citizen Centre and all it has to offer.
Good morning, everybody. I'm Sally Ashville, the immediate past president of the Senior Cits. Our President Cheryl is away having medical appointments this week. 3 years ago, Sue Starr came to the Esperance Senior Citizens Management Committee with an idea to hold a Dying to Know Expo. She addressed the committee and the concept was embraced enthusiastically by all our members. I did think at the time it would be a once-off. That very first Expo was well received, packed out. In fact, we noted that some tweaking would have to happen to the rooms should we have another Expo. Well, here we are hosting the third Expo. Thank you so much, Sue, Meredith, and other members of your group who work very hard to make the event flow smoothly. It is educational to all who attend. Thank you also to our kitchen volunteers who have prepared and will serve an all-day morning tea for $5. Your work is so appreciated. We here at Senior Cits, no, I haven't finished yet, there's more. We here at Senior Cits wholly support Sue. We all want to and need to know about the end of life, but all the members at Senior Cits are determined to live full, active and enjoyable lives while we're still here. Our new President, Cheryl Green, and her executive committee work very hard with advertising and promotion to grow our membership, which at present is around 300. We offer something for everyone, from exercise classes to china painting. 28 individual, well-supported groups use the centre. They're all in the brochure, if you'd like to grab a brochure from over there and have a look at the work that we do here. For example, our ukulele group has spare instruments, so you'd like to try and come and play ukulele, we have instruments that you can have a loan of. The paint by numbers, we have kits that you can buy, or you can buy a kit for yourself online. The extent of activities, take a brochure and see for yourselves the extent of activities available for a healthy physical and mental life. This year our centre won the active group category at the Australia Day celebrations. The certificate and medal are on display. The Esperance Senior Citizen Centre has been self-governing for over 6 years now. Our Shire gave us a sizable grant spread over 5 years to help with expenses, which were related to becoming self-sufficient. We took up the reins and our volunteer management committee now runs the centre in a very efficient way, led by our President, Vice President, Secretary and Treasurer. We provide a wonderful home-style cooked meal on Wednesdays, lovingly prepared by our volunteer cooks and the amazing kitchen crew who are, but we're always looking for volunteers, so if that's you, please let us know. I can't emphasise enough the benefits of becoming a member of if you are over 55. There really is something for everyone, and if we don't already have it, we will do our best to provide it. we have a suggestion box in the foyer for your use. And so to finish, I do wish Sue and all the Death Cafe members a successful Expo, and we'll welcome her back if and when there is another one planned. Thank you, everybody. Thank you, Sue.
Last year we had a board up with all of the different posters for each of the activities, but there's so much that goes on here. Honestly, you hardly ever walk in without there being something to do in here. So Jo Ramsaw, she's our cancer support nurse. She's going to come up now, and we've got a presentation that she's going to help us with. Thanks, Jo.
It's wonderful to see sort of the Expo, and this is your third year. That's fantastic. And from small things, big things grow. So I can only see in the community more and more people becoming aware of the death cafes and the Dying to Know Expos. So it's certainly the feedback we're getting through our cancer unit. More and more people are aware. So that's wonderful. So, all right. So what's my role? What do I actually do? So the role of the cancer support nurse is many and varied. So we accept and support new referrals when people are diagnosed with cancer. That can come from many avenues. Most of it is from the GPs or the tertiary hospitals after people have gone up to Perth for investigation. So we offer psychosocial support. I make contact with you a variety of ways. We try to attend oncology clinic appointments whenever possible with you. I also work in our chemotherapy unit, so if I'm not at a clinic appointment with patients, I'm usually working in our chemotherapy unit. We put in referrals to allied health, dietitian, physio, and so on. And I facilitate the cancer support group once a month. We're hoping to start up again next month. We usually just do once a month throughout the year, and we have guest speakers come along, or it can be a social get-together. We even had some of the cancer support group meetings here in the meeting room over there, which patients have really enjoyed. Just getting together and knowing other people are going through a cancer journey can be invaluable. I advocate for patients, sometimes with the PATS office, sometimes with the tertiary hospital, and there's the endless paperwork. And I particularly like this caption where it says, "Do you remember when all we had to think about was the patients?" Quite often now there's a lot of paperwork involved with any healthcare, as you know. So, I'm sorry, this writing might be a little bit small. I'll read it out. So, local services, what do we offer in terms of cancer support? Chemotherapy treatment. Many of you may know or may not know, we have a chemotherapy unit at the hospital, so we can treat most cancers here locally. We do an oncology service. We coordinate appointments, and that can be via telehealth, phone consults, or face-to-face consults. The diagnostic services available here at Esperance is things like X-rays, CTs, pathology and ultrasound. There are some things that we cannot offer, which are things like MRIs and PET scans. Those terms might be familiar to you, and you do need to travel for those. But we try and keep most of the diagnostic services what you need here. We link in with visiting services, such as the mobile osteoporosis van that comes down once or twice a year. And we do referrals to other health agencies. Cancer support group and the Look Good Feel Better annual workshop. Is anyone familiar with that or has attended that? No? Oh, thank you, Meg, in the back there. So that's a workshop that we run for cancer patients, particularly going through treatment, and it's learning about skincare and hair care while they're on a treatment regime. And I think we just did, last year was our 10th year. We run it usually in October or November, and it's always been quite well received. I know, Meg, you enjoyed it, yes? That's it. So we run one of those, and we do lots of education sessions. Last year we did an advanced healthcare planning workshop at our support group, and a variety of guest speakers. Whatever the group is interested in learning more about, we try to facilitate that. So sometimes we'll have the physio come and talk, sometimes we'll have the dietitian come and talk, and so on. So I don't work on my own. I work as part of a team. which I enjoy very much. We do meetings, we link in with Kalgoorlie a lot, we use telehealth a lot for those sorts of things. We work as a team with PATS. Cancer Council, you might be familiar with. We do a lot of linking in there for financial assistance, support and accommodation. Possibly most of you have heard of Crawford or Milroy Lodge, so we do a lot of linking in there. We liaise with external services specific to the cancer group, so the Leukaemia Foundation or the prostate. And I'm also the McGrath breast cancer nurse, so we link in with the McGrath Foundation as well. We advocate for patients to have services locally, whether that's dental or the visiting cardiologist might come down, and patients while they're on treatment might need to have these investigations. So we will link in and refer to try and get you to have as much as you can, as much as you need locally. And we link also in with palliative care services. Now, I did hope that my colleagues would be able to join me this morning, and I believe Simone has spoken. She's our social worker at previous expos, but she's unfortunately been away sick this week. So I'm hopeful that one of my other colleagues can join us, but we'll just wait and see. All right, so our passion is optimal care for country patients and ensuring local people can access the services they need closer to home. There's a commitment to improving outcomes for patients in country WA. Why should distance be a barrier to healthcare? And I think that's something that, you know, in these more rural and regional communities, that's a really valid question. Just because you live 800 kilometres away, why can't you access the same level of healthcare as you would if you lived in the metro area? One of the things that patients do say to me is when they're having treatment locally for cancer, they say, it's so good, we don't need to pay for parking at the local hospital. And I do particularly like that caption, and it says, he was only here as a visitor but collapsed when he saw the car park charges. I particularly like that, and that is, it's very interesting because I go up to PCH and now RPH for my son's appointments, and you never know how long the appointment's going to take, and so I can't imagine what that must be like for patients going through cancer treatments to go up and, you know, do I pay for 2 hours of parking or am I going to be there all day or possibly overnight? So it certainly does rack up. So we're a public hospital, so we're covered by Medicare. So that's quite a good thing. So public, if you have treatment or you go to a public hospital, tertiary hospital, they will automatically refer you back to us because we are a public hospital. If you go through the private sector for your cancer treatment, they won't necessarily refer you back because private doesn't always refer to public. Just something to be aware of. Which is great. These events are great to raise awareness of what's available locally. So if you do go down the private pathway, you can ask for your paperwork to be referred to us if you prefer to have treatment locally. We're very passionate about patients having less travel to and from the metro area. I think we've all sat in a car, have we not, for 8 hours. And it's pretty exhausting. So imagine if you're doing that while you're on treatment. It's just exhausting. So, and less travel within the metro area. So even though you might have to go to Perth for some things, you know, we try and line up appointments for you. I don't do miracles, but I certainly advocate for you. So instead of needing a scan on a Monday and then, you know, something else on the Friday and then something else the following Friday, rather than having to go up and back and up and back and up and back, we try to advocate for you to have everything in the same week so that you don't have to keep doing all that travel all the time. Preferably on the same day would be great. Patients can continue to work while on treatment, so there's no reason you can't work while you're on treatment. It just might have to be modified or lighter duties while you're having that treatment. So, you know, we're really encouraging of that and can advocate for you in terms of liaising with the oncologist and work for you. We are the same staff each time in our cancer unit, so that's really nice. And the feedback that we've had from patients is it's so nice to see the same people every time you come in for treatment or for appointments. And every time they phone the unit for whatever, they know that one of the 5 of us, and they know us all, so you know who you're speaking to. I think that's really nice, a really nice kind of community touch. And patients have also said to me they have a lot of anxiety about not knowing anyone in the big smoke. So sometimes you don't know anyone going to Perth, you don't have any family up there, you don't have any friends up there, you're feeling quite isolated. So this drives our passion for optimal care for our country patients. So the pathway for rural cancer patients, just a guide, your GP will refer usually to a metro hospital for further investigations. You might have initial diagnosis, surgery, more pathology, a treatment plan might be formulated. Then you can be referred back to Esperance and the oncologist that visits here, and then the treatment plan's put in place. So, as I say, I'll make contact with you, put in referrals, attend clinics. I'm also part of your treatment team, and I'll support you as needed throughout and link in with the other services. So here, I just thought this might be of interest. As you can see there was, in 2017, there were over 13,000 cancer diagnoses in WA rather, and it's predicted in 2025 we're going to have 17,000 cancer diagnoses. That covers all cancers, that's not just one specific cancer. And as you can see, cancer deaths back in 2017 were over 4,000, and in 2025 it's going to be 5,000. Now that's not a massive jump, and that's thought to be because there's a lot of early screening programs in place. We've got the Breast Screen WA bus that comes down. There's the skin cancer bus. There's loads of things that now visit Esperance, which is fantastic. So can I encourage everyone, if you don't already access those, please consider encouraging yourself and family to go along to these, because if we don't use these services, we're going to lose these services. So early diagnosis leads to better outcomes. Sorry, I've probably put the writing a bit small, even for myself. So the commonly diagnosed cancers in Australia in 2023 was prostate, breast, melanoma of the skin, colorectal or bowel cancer, and lung cancer. So they're the 5 main cancers that are diagnosed here, in Australia, but certainly in Esperance as well. Now, I put this slide in because I thought it was quite interesting. One of the questions I've been asked while I've been in this role is, does Esperance have a higher rate of cancer? Every second person I know seems to have cancer. And I thought that's a really good question. But what is the answer to that? So I went onto the Bureau of Statistics. This is freely available. You can do this yourself. And I thought, what are the numbers? So the most recent statistics are 2021, and the rate of cancer for Esperance was 3% rather, so 411 people. That's how they broke it down, and that's people in remission and on current treatment. And I thought, how does that compare with WA as a whole? So WA currently has a 2.7% rate of cancer. So I thought, we are a bit higher then. Not much, but a little bit higher. And then Australia-wide, it's 2.9% people are diagnosed with cancer. So I thought that was quite interesting. But can I also bring to your attention the other statistics as well? Things like arthritis, dementia, diabetes and heart disease. It's all very much dependent on the population cohort. So Esperance is considered, like a lot of people come down here to retire, so you have to sort of bear that in mind as well. So you could say, yes, but it does need to be taken with a grain of salt and put into the bigger picture as well. So history of the Esperance Cancer Services. Prior to 2008, country patients had to travel to Perth or Kalgoorlie for treatment. So it was decided that in 2008, a chemo unit needed to be set up so that we could treat some patients here so that they didn't need to keep travelling. So that was open at three days a week for treatments. In 2010, the CT scanner was built up at the hospital. And then the Cancer Council funded a cancer support nurse position, which was Ali. And then in 2013, a second oncology nurse trained in our chemo unit. And then in 2013, the McGrath funded a breast cancer nurse position, which was myself, and I also trained in chemotherapy. There was an increase in 2019 in oncology clinics. So our visiting oncologist increased, so they would come down for face-to-face clinics and then do follow-up with telehealth clinics. In 2020, our chemo unit expanded to 5 days a week for treatments. And in 2020, we also expanded a haematology service. And then palliative care and the palliative care social worker joined our team. 2020 was quite a big year. There was a lot of funding kind of available for all these things. And then in 2023, we started the infusion lounge for non-cancer treatments, because prior to that, everyone who was on an infusion would actually come to us, but simply we had more numbers, more patients coming through with cancer, so we had to make arrangements for our non-cancer patients. So, and the caption says, "Nurse, with this chemo cocktail, get me some mixed nuts and pretzels." So it's not quite like that, but we do look after you while you're in the unit. So where are we today? We have 2 to 3 visiting oncologists, face-to-face and telehealth clinics. We have 2 treatment chairs, which look a bit like that, quite comfortable. We have 2 full-time staff, 2 part-time and 1 casual who work in chemo. We have a cancer support nurse and a McGrath breast care nurse, which is me, both of those at the moment, and ambulatory care support. We have palliative care team, allied health support, and you might have been aware that there was a media release last year that the McGrath Foundation and the government were teaming up to provide funding for specialist cancer nurses other than breast. You might have seen that on the news. That's going to be, so watch this space, that'll be the next 4 years or so. So increasing funding for cancer nurses. And all of us who work in the unit, we all have plans for cancer services expansion. We just got to get management on the same page. But we're all very keen for expansion because we can see the need. That's just some resources there. Do I have a look? Thank you. Does anybody have any questions or would like to comment?
I was just asking Jo about age. You know, like you've said that a lot of people come here to retire, so that puts our age group up.
Yes.
Not by much, is it?
No, not by much.
No.
But bear in mind, this is a WA-wide initially and then Australia-wide, and it also includes a lot of places, say mining towns and things like that, which perhaps don't have the same cohort of people.
Okay.
Yeah.
So as far as people who are living with cancer, have you seen more younger people? That's what I'm trying to say. Is there more younger people being diagnosed with cancer, or is there an age group that you say like is the danger time?
I'm not sure there's a specific age group. Great question. We are seeing younger people diagnosed with different types of cancers. But then you have to think about, is that because there's more screening programs available and their cancers are getting caught earlier? I don't know. It's very interesting to see how all of this will go, but certainly we do have some younger patients currently receiving treatment for different cancers. Yeah.
Okay.
Yeah.
Scary, isn't it?
Yeah. Oh.
Anyone else got a question?
So Albany was very similar for these statistics as well. They've got quite a similar cohort population, so a lot of people do go to Albany to retire as well. So it was quite interesting, like just looking at all because they take everything on board. Like it was quite a comprehensive. It was the census that they did a few years ago, so they didn't break it down to what specific cancers were in each area. It was more just a general overview. So it's only, but like when you think about it, Western Australia is 2.7% and Esperance is 3%, but you need to take that as part of the bigger picture. We are also a coastal town, so we just need to be aware, like more people are outside in the sun, like there's a whole range of factors that they take into account, but this is what was available on the Bureau. So, yeah. So it does feel sometimes like, yeah, we do have every second person that, has cancer or has experienced cancer, or we know someone who's had cancer. Yeah, it does feel like that sometimes, but we're sort of on a par with other country towns with the same population.
Just a general comment, where you were talking about making appointments in Perth and trying to line them all up. Anyone else had the same issue with people in Perth do not know where Esperance is. And they'll say, can you just pop up and see us the day before and that sort of thing. And it's just, I'm sure everyone's had the same thing, but you're making MRIs or anything, but people just don't know where we are.
No.
That's right, Karen, I don't.
That's very true. And if I may add to that, we've also had the situation where patients have phoned us and said, I don't know what to do. The tertiary hospital has phoned me and it's, 4 o'clock on a Thursday afternoon and they want me to be there at 8 o'clock on Friday morning for an MRI. I'm like, well, that's clearly not going to happen. So let me negotiate for you. So, yeah, it's getting better, but it's still out there, I think, yeah.
Can any of them be treated surgically, or if there's any apart from the usual ones we get on legs and body? Does everybody have to go to Perth for that surgery?
Mostly, as a general rule, surgery is something that's done at the tertiary hospitals. Sometimes Albany will do the particular surgery. It really will depend on the situation. So generally most patients will go to Perth for further investigations, surgery, and then their follow-up pathology appointment, and then a treatment plan is decided from there, and then they will be referred back to us from there. Yeah. That's a great question. I know that there's education that goes on for GPs as well as other health professionals in regards to cancer. So I'd like to think that yes, knowledge is improving and increasing all the time. So I would like to think that the doctors would ask you those sorts of things. But perhaps the best answer would be advocate for yourself. Go in and say, I would like these checks. For my age, whatever that might be. Do I need a bowel screen? Do I need a mammogram? Do I, all those things. So it is a lot about self-care as well, and just talking to your GP about those things. So great question. Yeah, yep. So, may I just share a funny story? Sorry, have I got time? Yeah. So, as you know, the breast screen van comes down annually now to Esperance, and you'll see on most of the advertising material it's aged 50 to 74 is their target audience for mammograms. And at the time, this is a few years ago, at the time I was 40 and I thought, here I am preaching this to all my breast cancer patients, go and get a mammogram, rah-rah. And I thought, perhaps I should practice what I'm preaching. So I thought, but I'm not 50. I just feel that's not right to wait to 50. So I actually phoned Breast Screen and said, I'm not 50, but can I book in for a mammogram? And I explained the situation. They said, no, it's fine. If you're over 40, come on down. So I went, sure, right, great. So I made an appointment and I went down and I had the experience of a mammogram so that then I could truthfully say to other women what it was all about. And I'm really, really glad I did that, because now every 2 years I just automatically am on their system and I get a mammogram. So sometimes it's about advocating for yourself and just, those sorts of things. Yeah, so, yeah. And I think, I believe the bowel screening, don't you get a letter in the mail when you're 50 saying, congratulations, you're 50, here's your free bowel kit, whatever it is. So just use those services.
We should have got ads for that on television.
Yeah.
Excellent. Oh, thanks,
dear.
Jo.
All right, thank you.
Thank you, Jo. Thank you very much.
So aged care is the support provided to older Australians in their own home, community or in residential home care. It can include help with everyday living, healthcare, accommodation and equipment such as walking frames or ramps. Government funded aged care services are available to eligible people. So one of the first things to actually find out is if you're eligible for the aged care support that is offered. So in the main, if you're over 65 or over 50, if you are in Aboriginal or Torres Strait Islander, then you are usually eligible for some sort of form of aged care assistance. Okay, so there's a bit of a journey that has to start at one spot, and that starting point is My Aged Care. My Aged Care, it can be accessed online or it can be accessed through a phone number. That'll be on the next screen. But don't need to make a note of that phone number. I've got some leaflets you can come and pick up which has it in. So there's a number of different types of aged care. You will see the services at the endpoint here. Commonwealth Home Support, home care packages, residential care and residential respite are all available in Esperance. The only ones that aren't available here are transition care and STRC, and I'm not even sure what STRC stands for, I'm sorry. So in order to access those, you have your registration with My Aged Care by either phoning up their helpline and talking to someone there and actually getting yourself on that first step and saying, I need a bit of help. And it could be a bit of help with mopping the floors, as I heard from someone this morning. It could be that you are no longer able to drive and you'd like some help with transport to your appointments or to the activities you usually undertake. So it can be a variety of things, or it might be to the extent that you are no longer able to shower yourself and you need some assistance with showering. But if you've got that assistance, you can still stay at home, you're still safe. So it can be actually a wide range of different things that you would do. So you can search for My Aged Care online. If you're computer savvy, put My Aged Care into it and it'll bring you up with that page there, which you're looking at it. But if you're not, the phone number is the way to go. So when you ring up or when you're online, you'll be asked to explain your situation. So eligibility is based on the certain things that we will tell them about. So they'll give you about a 5-minute chat to say, what is it you're looking for? What is it you're feeling you need some assistance with, and why is that? You provide them some details. One of the details you have to provide is your Medicare card. So when you're actually making that phone call, have your Medicare card available to them. You can actually get someone else to help you do that. You don't actually have to do it yourself. If you are in the same room, you can actually say, I would like my daughter, my son, my friend to be my representative, and they will make sure that that is okay with you. They can do that on the phone. They'll speak to one and then they'll speak to the other person. And then once they've spoken to you about all that and said, yes, you are eligible for My Aged Care, I'll set you up with an assessment time. So they will, with those details, they will then get hold of the assessors. This is where it's a bit complex at the moment. At the moment, there are 2 forms of assessment. One form of assessment is for the lower types of care and those people who only need 1 to 3 types of services. There's some pictures a bit later that will make that a little clearer. Those people who are needing something that's maybe a bit more medically, a bit more clinical, as they call it, may have an ACAT assessment. That's someone who needs more care, more assistance, and is likely to need 3 or more types of services from a service provider. The ACAT assessment also assesses for people to go into respite if they need it later, or go into nursing home services. So it's a much fuller assessment that happens. The assessor will have a copy of the information that you gave My Aged Care. They'll know what you talked about on the phone or what you'd put into the form that's online. It'll give them an idea of the type of things that you'll be needing and the type of things that might be available to you. So they'll ask about the support that you already have. What family support do you have? What friends support do you have? And if that's ongoing, or if there's it may be that you've got family who used to help and they're now moving away. So they'll look at your situation. They look at your health, they look at your lifestyle, and they look at your health concerns. So looking at your lifestyle is like, what do you enjoy doing? What can we help you continue to do that is going to keep you independent and at home? How you go about completing daily tasks. Just because you can't mop that floor safely anymore doesn't mean that you can't still do your shopping or you can't still do your cooking and go to the senior sits for the activities you do. So it may be that there's just a little bit of help to keep you going on those things. Are you having problems with memory? I'm always having problems with my memory, particularly when it's someone's name. Are there any issues relating to home or personal safety? So is that step going out the back now something you can't manage to go and put your washing out? So it might be that there's an assessment done so that you can have a ramp put in or smaller steps. Family and community activities, what's going on around the place that you would like to get involved with but you're finding it difficult. And they may get you to speak to your GP and ask some specific questions. So when you've had your assessment, you will receive what they call a support plan, and you'll receive some codes and numbers which allow you to access home care, in-home care from either myself or another organisation. So as I said, aged care programs are a bit of a continuum. You have your entry-level in-home support, which is called the Commonwealth Health Home Support Programme, or CHSP, commonly known as. More complex, it's the home care packages and residential care. So our entry level, type of services available for CHSP. So the only ones that aren't available here are the cottage respite, and I think that's it. So everything else is available here. The only one we don't do is the home modifications and maintenance. That is actually referred through the OT's department at the hospital. So we can help with providing social support either individually or in a group. We've got a number of groups that operate at the moment, and we're soon to be moving into our brand new, wonderful looking day centre when it's finally finished. So transport. Transport can be a regular thing. You can have the transport to come here for lunches, perhaps, or a particular group you're undertaking, or it could be that you've got doctor's appointments you need to keep. So we are able to provide transport given notice. There are times when our staff are fully occupied, so ringing up the day before and asking for transport doesn't work quite often because we haven't got any staff members available. So with notice is always appreciated. Domestic assistance. So the domestic assistance we provide is what we call a hygienic clean. So it's helping you to keep things hygienic in the house. It's not that deep clean that you might get at the end of a rental. It's the hygienic clean. It's keeping things going with you. And it's done for CHSP, it's done in what we call the strengths-based approach. So if you can do it, you do it. If you can't, we do it. So if you can still do the dusting safely because you're able to do that, then we will let you do your dusting and we'll do the other things around it. Personal care, it can be all the way from what we call a standby shower. So that can be, I don't feel safe in the shower at the moment on my own, but if someone's in the house, then I feel I can then go and have my shower. So it can be what we call a standby shower right from that point, all the way up to having someone who's needing to be hoisted and put into a special chair and taken into the shower and actually washed. So that's our high care showers. Flexible respite can be offered at times when we've got enough staff, if it's just a one-off or at various times, and we can assist with things like coming into the home and spending some time with a person. So if you're a carer, so we can come in and spend some time with that person while you go out and do the jobs that you need to do. That can also be counted as social support. Our Meals on Wheels are available. And we have nursing care and allied health therapies. Okay. Complex home care is your HCP packages, home care packages that they do. Very similar to the previous one. They range from social support services, social activities, joining a group, one-on-one support in town, personal care, allied health services, and care coordination and case management is with those. Okay, a little bit about home care packages. Home care packages, people will often come away from an assessment about home care packages and go, oh, I'll get to the right page so I get the right figures on that one. If I'm on a home care package level 2, for instance, there's $18,000 that's available to me per year to actually have some health care. That's what the government puts aside for a level 2 package. And for that level 2 package, that's what we can access as an organisation for your care. It doesn't mean that money is there, so if I don't use the care, I can then have the money in my pocket to buy something else, unfortunately. So, and they are very particular about what things can be bought and what can't. So when we move up to the level 3, your level 3 packages for intermediate care, and that's worth about 8 hours of assistance per week, roughly. It depends on the assistance you're needing, because if it's nursing assistance, it's actually more, it costs more, so it might actually be less hours if it's nursing assistance. And it goes all the way up to level 4, which is around $60,000 of assistance, but that only equates to about 12 hours per week. So you can see even at a level 4 high level care package, it's not enough to keep someone in their home totally and have someone 24 hours a day assisting to keep someone in their home. That's where the government suggests that you then move on to looking at your residential care. Okay? So, what will home care cost? So whilst it's subsidised by the government, it's not actually totally free. Right? And that actually can be a bit of a surprise to some people, particularly when they hear that this money is available, different bits of money are available. Under CHSP, the government expects that everyone will co-contribute. So there are fees in place for, such as your Meals on Wheels. Meals on Wheels is currently $13 that you contribute to that, because the government feels that you should pay for your food side of it. Everything that's done for in-home care is not about providing an alternative to your income, it's about subsidising the care that you need because of your ageing process. So there is a bill at the end of the month, unfortunately. With a home care package, as I said, there is a certain amount that we're allocated to allow for in the spending and in the care that we organise for you and we organise with you. And given that sometimes people do go over that, and sometimes they don't. The level 3s and level 4s are quite high in terms of, because you may need equipment. So that wheelchair may need to be something that's bought for you or the person you're caring for. Or it may be that you need the hoist, or the Sarah Steady, which helps you get up, stand up and move around. So if you're in a home care package, you actually have to go and have an assessment with Services Australia. CHSP you don't, it's just general, but for a home care package, you actually have to have your income assessed to decide how much your per day contribution will be. And if you're full pensioner, you will not pay anything towards your home care package. If you are fully funded, if you're a fully self-funded retiree, however, your package can cost you up to $35 a day. So that's about $1,000 a month. So when people don't understand that side of it, again, it can be a huge shock. It doesn't matter if you're on level 1 or level 4, you pay the same per day amount for your home care package. So it's really worth having a look at what the costs are for yourself when you're looking about what you need. But please never make the cost stop you going to get that care you need. There are other ways around it. There's always some different ways that we can actually look at to assist you. Okay. There have been lots of aged care reforms over the last 12 months, and one of those is to have Services Australia have some specialist officers to help explain. I'm not going to go through this slide because we don't actually have one. There's only, I think it's 4, there's only 4 throughout WA. They are trying to extend the Services Australia's specialist areas, and hopefully over the next couple of years we'll see in our own DSS office that we would have someone down here. Some of the other reforms that have come into play over the last 12 months have been a new bill which is coming through to give us a new act. That's due in July this year. I don't know if you've seen any of the information around that, about the new act, which will give us some new standards to work to. Yay! Another change of paperwork for us. But it will simplify the assessment system that I was talking about before. So at the moment there's 2, you could either have a RAS assessment or an ACAD assessment. It's going to become a single assessment, and that's coming in July. So if you don't get if you don't get through to doing this process until after July, hopefully there'll be a single assessment and you won't have to have that decision of which one you're going for. So at the moment, we are working under the Commission with 8 standards. That is going to go down to 6 standards shortly. But it's all about being person-centred, and it's all about working with you, not throwing things at you that you may not need. There's a lot of information. There's far too much information in some cases, and it gets very confusing. And if you go through some of the websites, I end up in a bit of a rabbit hole, finding all sorts of different things when I'm looking for it. But there are some general things that are really useful for looking through yourselves, and that is the My Aged Care website. So the My Aged Care website is easy to Google, or you can phone them up on 1800 200 422. Now I think I've rushed through a lot of that. So if there's any questions, please let me know.
I've just been through all this with my mum, and the one thing that I found quite frustrating was I couldn't find her birth certificate, her marriage certificate, and when you upload these documents on the one particular site that I was on, it asked for a birth certificate, so I had to go and order a birth certificate. That was $60, so I ordered the birth certificate, and then it wouldn't let me go any further through the document until I uploaded the birth certificate. So I did that, and then the next question was, after I uploaded it, is this her current name? Well, no, because she got married. I couldn't find a marriage certificate, so then I had to order a marriage certificate, another $60, another 2 weeks to wait. So this particular form I was ready to get the computer and chuck it out the window and say, stuff this, is not going to happen. The only other piece of advice I would say also is, if you hand your driver's licence in, you don't have any identification. You can get a photo card, but once again, with this particular website that I was putting it through for the My Aged Care or Centrelink or whatever, Mum had no identification because she'd handed a driver's licence in. The photo card wasn't sufficient enough to have as ID. She didn't have a passport, so you then have to go through Centrelink and do other ways of doing it. So it becomes very frustrating. And I'm not the best computer literate person around, but I can still follow my nose. So that kind of stuff, if you're going to hand your driver's licence in, get all this stuff. I would recommend with the My Aged Care. I've got a My Aged Care number already. So hopefully when my time comes, it's already, Kevin won't have to worry about it. But it becomes very frustrating because you don't have all the documentation. If you don't have all the documentation and you don't have any identification, so get it before you hand your driver's licence in is what I would be saying.
Not so much a question, but like Heather, a bit of handy advice. dealing with Centrelink, if you're not a pensioner, the complexity of the forms for a home care package or even residential care get more and more complicated. So you probably, if you've got someone who can help you go through that, certainly get them to help you. I don't know if S-Care still helps, does that form filling? Yes, because it's very intense. If you tick some box and go, oh, now you need form XYZ, and then you tick that, oh, and another form, and you don't really have to have too much money in the bank for it to kind of just click over. And then the other thing, I've had the experience recently where I put my forms in on the 7th of September. I went back to our local Centrelink office, which I have to say, if you've dealt with them, they're really, really good. We're so fortunate in Esperance. There's never a line out the door, and you know, it might seem a bit frustrating to sit for 20 minutes, but look, they're a great team in there. So I went back, I think 2 or 3 times to check. Oh, no, they're still assessing it. Oh, there's been floods, you know, in the east, so they take the assessors off. So finally, about 2 weeks ago, I went to Rick Wilson's office, and within 2 weeks, bang. Hello, is that you, Elaine? Yes, this is Services Australia calling. So if it starts to delay, go straight to Rick Wilson's office and they will assist you. And the same with entry into the Esperance Aged Care Facility. It's very important, if you're even thinking about going in yourself or a loved one, to start doing your means testing. And regardless, you have to do it whether you're a pensioner or not. Even if you're a pensioner, you still have to fill in the forms. You have to keep skipping, and they're pretty simple. But if you can get all that done before you go in, that's a great benefit to everybody. Mm.
Nellie, did you try an accountant at all?
I had to use an accountant, yeah.
I was going to say, I'm not sure if all accountants do it, but I do know my parents used an accountant to fill in the forms.
I had to, yeah. If you're a self-funded retiree and you have an accountant, I had to get them to fill in that part of the form, definitely, yeah.
Anyone who's been through the process knows that it's a bloody nightmare. And I've got, I found this little book, this big book actually, I found this at an expo I went to last year. What was the name of it? I can't remember. It was at the convention centre in Perth, a massive big expo, much bigger than this, with all these little stalls. And I found this book, and it's got everything in it. And a lot of it is advertising for Perth-based home care providers, like Esperance Home Care is for us. It's got a lot about nursing homes up there, which aren't relevant to us. But for family members, it's great just to have on hand. You can see the process, like you're saying, Nellie. It's all set out there. What you do if this doesn't work and all that sort of stuff happens. So, Eric, the people, I got in touch with the publishers. They sent me boxes of them. So Erica's got heaps up there. Even if you don't need it now, just grab one because they're great to have. Sometime we're all going to need it. The ACAT team here in Esperance have given us some localised little kits as well. They couldn't be here, but they've given us kits, and there's these little smaller booklets. When I was in Perth at that expo, all of you will know Jean Kitson. She's an Australian comedian. Oh my God, her parents are going through this whole assessing process, and I bought her book when I got back to Esperance. You can see how much I've used it. Now, she's amazing, and she was saying, when you need to phone my aged care, do it at 8 o'clock in the morning. Arm yourself with a book or a cup of coffee or a glass of wine, she said. And know that you're going to be on the phone for a long time, and know that they're just going to tell you to do something else, and then you've got to go back. And her book is absolutely amazing if you want to read it. If you're going through the process, or you've been through it even, it's really good, and it is available on audio book as well. So it just makes all this stuff much more light-hearted, even though there's a lot of really good resources in there. So there's heaps of information, and honestly, I wouldn't wait. Like Heather said, you get your My Aged Care number, then you've got your foot in the door, and if you don't ever use it, doesn't matter.
Hello, my name's Louise. I'm a dementia support specialist from Dementia Australia, which means that my job is to provide education and support to people living with dementia, people concerned about their memory or cognitive changes, and their family and friends who are supporting them. So I'm joined by my colleague Jane, she's up at the table, who works in the Dementia Friendly Communities team. So her job is about making communities aware of what dementia is, because as I'll show you, it's on the rise, there is a lot of it around, and the community can do a lot to enable a person living with dementia to keep living a good life and to keep living it at home. So there's a lot of information in these slides. I will jump over a few, so don't panic. I'm still going to touch on the main pieces of information. We've also got a lot of information on the table, 2 sheets in particular that Jane will hand out at the end that summarise what I've talked about, so you can look back at it, so you don't need to be frantically taking notes. Okay? So I'm not going to touch on all these things, but I'm basically going to start by giving a little bit of an overview of dementia in terms of its prevalence. I'm going to talk about how a healthy brain works. And the reason I talk about how a healthy brain works is that if we understand that, we can understand what changes we see with a diseased brain and why we see them. Then I'm also going to talk about the different types of dementia, not every single one, because there are over 150 different types, but the 4 main types of dementia and how they differ, so the different symptoms that you see. And then I'm going to finally talk about what you do if you're concerned about yourself or somebody you know, what the process of diagnosis looks like, and what non-pharmacological supports are available out there, and particularly what's provided by Dementia Australia. So up front, I'm just going to let you know it's not a sales pitch. Dementia Australia is funded entirely by the National Dementia Support Programme, which means it's federally funded, and any services that we deliver are free of charge at the point of delivery, so you don't pay for any services from us. Any questions before I get started? Okay. Okay, so why is it important that we talk about dementia? It's important because there are, at the moment, this year, around about 420,000 people living with a diagnosis of dementia in Australia. That means there are probably significantly more that they just haven't yet got a formal diagnosis. Of that number, almost 29,000 are living with what we call younger onset dementia. So younger onset dementia is the same disease, but it happens to be diagnosed in a person under the age of 65. So most people think that dementia is an older person's disease. The risk of developing dementia does increase as you get older, but it is a pathological change in the brain, and it can happen to people as young as in their 30s and 40s, and even children. By 2054, it's estimated that more than 800,000 people in Australia will have a diagnosis of dementia. And there's a couple of reasons for that, and it's in a little bit like the cancer nurse said before. The process of diagnosis, the process of understanding the disease, is getting better all the time. So people are being diagnosed earlier or more accurately, and we have an aging population. So we're surviving more other diseases, heart disease, diabetes, cancer, and we know that the biggest risk factor for developing dementia is age. Of those 421,000 people living with a diagnosis now, there are approximately 1.6 million people involved in their care. So that's the people who are paid to care for them, but it's the spouses, the children, the extended family who provide support. So you can see why I want to talk about dementia, why we want to raise awareness and make the community aware, because it affects so many people. Okay, So moving on to how a brain works. Now, I'm not a doctor and I'm not a neurologist, so this is brain biology 101. We're looking at a schematic view of the brain. When we talk about the brain, we divide it into 4 lobes. And those 4 lobes are primarily responsible for particular functions. But as you will know, the brain is very complex. All those lobes have to work together in order for our brain to operate. But it helps if we divide it up and talk about the main things that they do, because it helps us understand the symptoms. So we're going to start with the frontal lobes. So the frontal lobe is the bit immediately behind your forehead. It's responsible for what we call executive function. So the ability to make plans, to organize ourselves, to make decisions. So it's what makes us different from the apes. It is responsible for us stopping and starting actions. So motivation, having the idea to begin a task, knowing when it's appropriate to stop. It's responsible for regulating our behavior. So that filter, when you're thinking something and you don't actually say it out loud, or how it's socially acceptable to behave. So for instance, putting on your clothes before you walk down the street, going in the bathroom when you need to go to the toilet, that kind of thing. It's responsible for our working memory, so what we need to know in the moment, generating speech, and importantly, insight. So a person with frontal lobe damage lacks insight into how they're behaving, into how they're presenting, into how other people are perceiving them. They typically think that the problem is somebody else, not them. Okay, so you can see that if somebody has damage or a disease in their frontal lobes, it will become difficult for them to make plans, to organize, to motivate themselves. They typically become quite apathetic. It will be difficult for them to regulate their behavior. It'll be difficult for them to know what's socially acceptable in terms of how they're behaving, but also how they're talking. So maybe become very blunt and quite rude and selfish and inconsiderate of other people. And it can affect the way people speak. So their ability to choose words, to produce words, or to use the right word. Okay? Something to remember, I always find helps with a frontal lobe, and it might be because I have teenagers. A frontal lobe is not developed in a human, not fully developed until the age of 25. So when we talk about impulsive behavior in teenagers, it's because their frontal lobe isn't completely developed. Move that on to a person whose frontal lobe is damaged, and you can see why their behavior is going to change. Does that make sense to everybody? Okay, the temporal lobe is the part of your brain that's in your temples, so above your ears. There's 2 things going on when we hear. There's the ability to hear, which an audiologist is testing and maybe can correct with a hearing aid. And then there's the ability of the brain to understand what you're hearing. That's what the temporal lobe is doing. So the temporal lobe is processing the sound you hear. So let's say you hear a sound, but you don't see it. So we're sitting here and we hear an emergency vehicle go past with its siren going. The temporal lobe is telling us that's an emergency vehicle. That you're hopefully understanding the words I'm saying is because your temporal lobe is interpreting what I'm saying. Okay, so it's not the ability to hear, it's the ability to understand. Somebody with temporal lobe damage, so a disease that's in the temporal lobes, will lose the meaning of what's being said to them. So they'll hear the sound, they'll hear the words, but they won't understand them. Okay? Also quite common with temporal lobe damage is somebody who maybe learned English as a second language, starts losing their ability to understand English, but can still understand their mother tongue. The brainstem, that controls the involuntary function, so things that are happening all the time without us thinking about it. So your heart beating, your breathing, your blood pressure, sleep, coordination. And then we've got the parietal lobe, so that sits at the back of the head here. And the parietal lobe is responsible for what we call sensory processing. So sensory processing is the brain's ability to make sense of the information we're taking in through our senses. So our senses are bombarded with information all day long. You know, what we're seeing, what we're hearing, what we're smelling. The brain has to interpret that in order for us to function. Somebody with parietal lobe damage is not interpreting what they're seeing correctly or what they're hearing, or particularly maybe what they're feeling. So the touch in terms of whether something's hot or cold. For instance, putting a hand to pull a hot dish out of the oven and not feeling the heat, but finding their hands are burnt. That's parietal lobe damage. It's the ability to keep attention, so to focus on something, start a task and see it to completion. Okay? Not walk away halfway through and forget that you were partway through doing it. Or to pay attention to a conversation or a list of instructions. So, you know, you might say, oh, can you go to the bedroom and draw the curtains and make the bed and pick up your hat because we're going out? If you've got parietal lobe damage, it's way too many things to remember. You can maybe go to the bedroom and pick up your hat, but you might have forgotten to draw the curtains and make the bed. The parietal lobes are responsible for the ability to read and write, and specifically to interpret what you've read. So you might be reading the newspaper, but interpreting what the story is, or interpreting what you've written, is difficult if the parietal lobe is damaged. It's responsible for calculation. So by calculation, obviously, I mean mental arithmetic, but I also mean the ability to handle money, the ability to tell the time. So things we take for granted as being able to work out how much change we're going to be given if we pay with a $10 note, for instance, that's parietal lobe. And what we call spatial orientation. So the ability to find your way in space. So that's to leave home and go for a walk and find your way back. That's the ability to drive down to town, know where you're going, and be able to drive home. And as dementia progresses, it's the ability to find your way around a house. So maybe from the bedroom to the bathroom, or from the living room to the bathroom, for instance. Then right at the back of the head, we have the occipital lobes. And the occipital lobes do for sight what the temporal lobes do for hearing. So again, when you're looking at something, your vision can be corrected by an optometrist by giving you glasses, for instance, or perhaps surgery for a cataract. But how your brain interprets what you see is a result of what the occipital lobes are doing. So somebody with occipital lobes will either see something differently, so their depth perception may be different, their ability to see change in tone of colour may be different, the placement of where something actually is. So I worked with a client whose husband had occipital lobe damage, and the way she first identified it was he was driving down the centre of two lanes. And when she said, can you put the car in the lane? He said, well, I am in the lane, because he saw the lane markings offset from where they actually were. But of course, what he saw was his reality. That's what occipital lobe damage is. An optometrist will tell you that your sight, your vision is fine, but it's the way the brain is interpreting what you're seeing. And then right in the center of the brain, and it doesn't look like this blue oval, is the limbic region. The limbic region is responsible for where our emotions and our memories are processed and formed. And a word that you will hear a lot connected with dementia, and in particular with Alzheimer's disease, is the hippocampus. Because the hippocampus is a very small part of the limbic region, and it's where the short-term memory starts, so where the process is coordinated. It's the place where Alzheimer's disease starts. Okay, so when you have disease attacking that part of the brain, that's why you get memory loss. Now, at the end, Jane will give you a sheet that gives you these diagrams and tells you all these things, so I don't expect you to remember them all. Does anybody have any questions about what I've shown? Okay, so when we talk about dementia, we use dementia as an umbrella term. So dementia is describing a set of symptoms that are caused by any number of brain diseases. So over 150 different diseases of the brain. But what they have in common is that they are all causing a gradual and progressive change in the way a person thinks and operates, such that they cannot operate safely independently. Okay, so as we age, everybody undergoes cognitive change. So long as you're operating independently, safely, that's what we call normal aging. It's where the changes are such that they impact the way you can look after yourself every day that we have cause for concern. It's important to know that no two people are affected the same way, because we're all individuals, our brains all work differently, our characters, our life experiences are all different. And also that it's not a normal part of aging. So we know the chance of having dementia increases with age, but not everybody who ages is going to get dementia. So at the age of 65, on average, 1 in 10 people have a dementia. At the age of 85, 3 in 10 people. That still means 70% of the population of 85-year-olds do not have dementia. Okay, so it's common, but it's not everybody. An analogy I often make in terms of that umbrella term is talking about a fruit bowl. So if you have a big bowl on your kitchen bench, and you call it the fruit bowl, inside your fruit bowl is an apple and an orange and a banana and a pear, whatever. So dementia is our fruit bowl. Inside that fruit bowl of dementia are all the different diseases. Okay, so I'm going to come on to those. Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, all different diseases. Like your apple, your orange, your pear is all fruit. Does that make sense? You will often hear Alzheimer's disease and dementia used interchangeably. I've got Alzheimer's disease, I've got dementia, therefore I've got Alzheimer's disease. It's not the same thing. Dementia is that progressive loss of function, the change in the symptoms. Alzheimer's disease is the pathological change that's happening in the brain. So it's like the type of cancer. It's like saying I've got breast cancer, not I've got cancer. Okay? It's important because, as I'm going to show you, the different dementias have different symptoms. So it helps you understanding if you use the correct terminology. The reason they're often used interchangeably is that Alzheimer's disease is the most common form of dementia. It's the one most people know about. Most people who have dementia, 60% of people who have dementia have Alzheimer's disease. Is that clear? Anybody got any questions? So normally when you say to somebody, oh, what are the symptoms of dementia? Most people will tell you it's memory loss. Again, because Alzheimer's disease, the primary symptom is memory loss. So it's the one most people know about. But hopefully what you picked up from when I talked about the healthy brain is that dementia can also impact language, so the ability to speak and the ability to understand when somebody's speaking to you. It can impact comprehension. It can impact a person's judgment, so the things they choose to do, the way they choose to behave. Actions that are out of character, for instance, may be symptomatic of dementia. It can impact a person's ability to make plans, their spatial orientation, so their ability to find their way around, and also to know where your body is in space. So take, for instance, you're walking through a door frame and there's a problem with spatial orientation. You might not position your body in the center of that door frame. You might constantly banging into the side of it or banging into things. because you think your body's somewhere else to where it actually is. And importantly, dementia can really impact a person's mood and personality. Okay, but we'll come on to that. Any other symptoms that people may have seen or may have been aware of? I'd just like me to go on and talk about the different types. Okay, so like I said, there are more than 150 different types of dementia. The four I'm going to concentrate on today are the four most common. So Alzheimer's disease, vascular dementia, Lewy body disease, and frontotemporal dementia. There is information on the sheet, the summary sheet that you'll get at the end about all of them. So this is what's going on with Alzheimer's disease. In the blue circle on the left, you can see a healthy brain cell. So that's your brain cell is the round bit, and then what we call the dendrites, the big long arms that come off it. And that's how brain cells communicate from one to another. So they send information from one brain cell down this dendrite, up another dendrite to the next brain cell. If you look on the right-hand side, you can see those white clumps of, it's called amyloid. It's a type of protein. So what happens with Alzheimer's disease is there's an accumulation of this amyloid into what we call plaques. They form these lumps, and they interrupt the messaging going from one brain cell to the other. Okay, so I often think about it a little bit like roadworks. So if you're driving down the street and there's a roadworks, you get a diversion and you can get to the same place, but it takes you a bit longer. So in the initial stages of Alzheimer's disease, you get that buildup of amyloid plaque, but we've got billions of brain cells. So the message can't get through one way, it picks another way and it goes round. Takes a little bit longer, but it gets there. But like if you were in town and they started digging up every road, it would get harder and harder to get through. As Alzheimer's disease progresses, you get more and more of these plaques building up, and there becomes less and less options for the brain to find the message, to find its way around the brain. Does that make sense? So you can see from the middle picture, and it shows you here as well, that what happens is as those plaques stop the flow of information around the brain shrinks. So on the left-hand side, you've got a slice through a normal brain. So you can see it's quite full of volume. It's quite puffed up. On the right-hand side, that's a brain that is affected by Alzheimer's disease. So you can see the brain has shrunk. So inside the skull, the whole brain has shrunk. The gaps are getting bigger. And if you look where the squares are, in particular down the bottom, you can see that memory and then also language, so the parts of the brain that are responsible in particular for memory, shrink the most as the brain cells die. That's why you're seeing memory loss as the symptom. And as the disease progresses, the brain shrinks more and more and has less and less function. Any questions about Alzheimer's disease? Vascular dementia refers to a type of dementia that is caused by an impact to the way oxygenated blood is circulating around the brain. So we know that our heart is pumping oxygenated blood around the body. It needs to provide blood to the brain to make it work. So the brain takes up about 2% of your body weight, but it uses 20% of your energy, so your blood flow that's going there. There are two ways that blood supply can be reduced to the brain. One is either through a blockage, so a thickening of the arteries or the other blood vessels, or a blood vessel in the brain can rupture and the blood can come out into the brain tissue and damage it. Typically, vascular dementia is caused by stroke. So that could be a large stroke that has a physical manifestation and you see paralysis of one side of the body. But more commonly, it's caused by a series of mini strokes or transischemic attacks, TIAs, that you don't even know you've had, or a person doesn't even know they've had. And the way they diagnose it is a brain scan will pick up those damages in the brain, the markers that have been caused by those attacks that you didn't know. It can progress over time if there are more vascular events. So when we talk about progression of Alzheimer's disease, we talk about a downward trend because those plaques are building up steadily and a person's function is gradually declining, like a hill. Vascular dementia is different because a person will plateau at a particular level and then a vascular event will happen and there will be a dramatic decrease in function. Okay? They'll then plateau again at the same level until there's another vascular event and then another. So it's more of a stepwise decline. Symptoms vary. They vary because, go back to that picture of the different lobes of the brain, it depends where the vascular event occurs in the brain. So if the event happens in the occipital lobe, you're going to see difficulty with the way the brain is interpreting what it sees, but memory might be preserved. If the event happens in the frontal lobes, you're going to see all those changes in executive function and behavior, but memory might be preserved. Does that make sense? There can be an overlap with Alzheimer's disease, so it is reasonably common that a person will have both going on at the same time. That's what we call mixed dementia, where there's that Alzheimer's pathology, so the buildup of plaques, but there's also a change in blood flow to the brain, and that's vascular dementia. Okay, moving on to frontotemporal dementia. Frontotemporal dementia has become a lot more well known in the last year since Bruce Willis was diagnosed, and his family very bravely came out and told everybody what it was in a bid to increase awareness. There's two main types of frontotemporal dementia. So one is what we call behavioral variant, which affects the way a person behaves. So this is really important because a person, their memory is operating as normal, okay? But they change in the way they behave. They typically become more selfish, less empathetic. They become quite inflexible, quite fixated on doing a particular thing or behaving a particular way. They often lose inhibition. They've lost that filter as well, so that's social regulation. And so they start behaving differently. Now remember that when we talked about the frontal lobe, we talked about insight. A person with behavioral variant frontotemporal dementia, or FTD, doesn't know that they're behaving like that. They think that the problem is everybody else. They think that they're normal. As a result, this can be really difficult to diagnose, or it can take a very long time to diagnose because it's often the word of one person against another. Okay, it's often misdiagnosed, particularly as depression, because it's a change in behavior that can mimic, like you can often see the same in depression. The other variant is a language variant, and this is how Bruce Willis's dementia started. So with difficulty finding particular words. Now that doesn't mean if you forget a word or the word's on the tip of your tongue and you can't quite get it out that you've got FTD. You haven't. This is progressive difficulty finding words, or using the wrong word, or not understanding the word that you're hearing or using. But it can also be difficulty producing speech, and that can manifest in two ways too. It can manifest in a person uses a lot of words, but they don't make sense. It's just a random collection of words that mean nothing. Or it can be that the speech really slows down and it's very difficult to produce the words. So there's a lot of different ways this can present. Any questions about FTD? It tends to be diagnosed in younger people, so people in their late 50s and 60s, but it is diagnosed in older people too. And then the other main form or most common type of dementia is called Lewy body disease. Robin Williams, remember the actor? He had Lewy body disease. I think his wife did a fair bit of raising awareness after his death as well. Lewy body disease is also caused by an unusual buildup of a protein. It occurs in the center of the brain cell, so you can see here that little blue blob. That's a Lewy body. It's called a Lewy body after Dr. Lewy, who identified it. Lewy body disease is is characterized by fluctuating cognition. So a person can present as completely normal, and then over a timescale of minutes or hours or days can be very, very confused, and then can go back to completely normal. So it's difficult. You can see it's difficult. It's also characterized by visual hallucinations. And for reasons we don't know, those hallucinations usually involve small animals and people, particularly children. As a rule of thumb, they're not threatening. So a person will be seeing something that isn't there, but they're not frightened by it, but they may be engaging with them. So they'll be talking about the rabbits that are running around the living room or the person who's in the house, and they're not there, but they're very, very real to the person. And it's really important to know that you can't dissuade them because that's what their brain is interpreting. Okay. Lewy body disease is what we call a spectrum disease with Parkinson's disease. So it's the same pathology, but it's a different part of the brain that's affected. So Parkinson's disease, as you probably know, starts with the physical changes, so the rigidity, the tremor, the slowness of speech, the slowness in movement. Not everybody, but a number of people who have Parkinson's disease will go on to develop either Parkinson's type dementia or Lewy body dementia, because it's the same pathology, just in different parts of the brain. Equally, people with Lewy body disease, not always, but often will go on to develop Parkinsonian type symptoms. Generally not the tremor, but often the change in movement, so the shuffling or the rigidity or the increased risk of falling, that kind of thing. There's a lot of people with Lewy body disease, because of that fluctuating cognition, also present with depression, so about 40% of people. Depression and those hallucinations can be treated by medication, but Lewy body disease is particularly sensitive to different types of medication. So they don't always make it better. They sometimes can make it worse. It's not a genetic type of dementia, generally. Most dementias are not genetic. There is some familial Alzheimer's disease, but it's in about 2% of cases, where you have instances of dementia within the family. So, for instance, my uncle has Alzheimer's disease, my grandma had Alzheimer's disease. It's because there are so many people who have Alzheimer's disease. It's not because he had it because his mother had it. Does that make sense? The familial types of dementia tend to be the ones that are diagnosed earlier, so 40s, 50s, not the ones that are diagnosed as people get older. Any questions about the four main types of dementia?
My mum's got macular degeneration very badly, and I know Deb's mum has as well. And they can get something as they age with their loss of sight. They can get something called Charles-Bonnet syndrome, which presents exactly the way as for those hallucinations you're talking about. So it's not dementia, it's to do with their sight. And apparently what happens is when they're lacking in their sight, their brain is making up all these other things. So can you explain the difference, or is it specific, like if they don't have a sight issue, would that mean that it's dementia?
Great question, and a very nice interlude to what's coming next. It's as if I planted you in the audience, see. So hopefully this will kind of answer your question. Dementia is what we call a last stage diagnosis. There are lots and lots of different diseases or different changes in health that mimic the symptoms of dementia. So the example you just gave is one. Depression, anxiety. Depression can make a person apathetic, can change their eating habits, can change the way they behave. Anxiety, the same thing. Sensory problems, so the example you gave in terms of sight, but also a person who's hard of hearing. They may appear like they're not understanding what you're saying. They may actually not be hearing what you're saying. I'm sure I'm not the only person who's experienced that. Lots of different disorders. So change in thyroid levels can cause confusion. Diabetes, if your sugar levels are not controlled, can cause changes in cognitive function. Malnutrition, so somebody who's not eating properly. Dehydration. Dehydration is a huge issue, because dehydration will often, particularly in residential aged care, will lead to a urinary tract infection. Infection changes the way a person thinks and causes confusion. Some kind of trauma, pain. If you're really experiencing a lot of pain, particularly if you can't verbalize it and have relief from medication, will affect the way that you present, the way you talk, the way you behave. Fatigue, delirium is a huge one. Delirium is very different from dementia in that you have a very sudden onset of symptoms, so very sudden memory loss, confusion, change in behavior. Side effects of medication and grief. You'll know that if you're grieving for somebody, you don't think as clearly. The important thing about this is everything on there can be addressed by a doctor. Okay? So we can treat dehydration, we can treat delirium, we can treat changes in hormone levels, right? And you will then see a recovery in cognitive function. So often we hear that people don't want to go to the doctor. They don't want to say, I've noticed I'm forgetting things, or I've noticed I'm not thinking as clearly, because they're worried that they're going to get a diagnosis of dementia. A large number of people who go to the doctor have something else, and you can get a script and you can recover function. Okay, so my number one message is that if there's any concern, is address it, because it might not be. So I'm going to skip ahead a whole lot of slides now so we can talk about, if you have concerns, what you do. Okay, so the first thing we're going to do with concerns that we have about ourselves, or in particular people we're caring for, is visit the GP. Now, we've talked about how change in the way a person has insight into their behaviour may mean that they don't think there's anything wrong and therefore they shouldn't go. At that point, I would encourage you, as the carer, to have a word with your GP and get it checked out in another way, as part of a general health check. Okay? A GP can do a thorough assessment in terms of a blood test, urine test, for instance, to rule out all those other things. They can also do a sort of screening in terms of cognitive ability. It's what they call a mini-mental. So they ask a series of questions. If they rule out everything else, they will then come to what's called a probable diagnosis, and they'll refer people on to a geriatrician or a neurologist or a memory clinic. What I always stress is that in that GP appointment, or in that appointment you're with a specialist, you have a finite period of time. And often, a person's function can change, and they can present quite well in a particular situation when they're not presenting that well the other 23 hours of the day. So, where I say here, take a list of your current concerns. If you're accompanying someone to the doctor or suggesting they go, you might want to take with you a list of examples of things that have changed, or things that aren't the way they used to be. And I suggest you write them down because A, they'll probably be a lot, but also you don't want to be on the spot in your 10-minute appointment to get all that information, recall all that information. So when a person is referred on to a geriatrician or a neurologist, they will start with the blood tests and the urine tests. They'll start with a detailed medical history of a person, but also of their family, and that's to rule out all the other things. There will be a physical examination. There will be a series of cognitive tests, and then a best case diagnosis is made by some type of brain scan, because that's where you can see the little marks on the brain scan. If you've had a series of small strokes, for instance, you might be able to see the shrinkage of particular areas of the brain, which will indicate what type of disease it is. You will often hear that a definitive diagnosis can't be made until autopsy. It's true, but they have got a lot of information that they can use, but also explains why your evidence is so important. Okay? Does that make sense? So hopefully what I've covered is an overview of dementia in terms of it is a progressive disease, it is a terminal disease, and there is no cure. Now, often we will hear that people have been to a specialist or been to a doctor and they've said, well, there's nothing you can do, just go home and put your affairs in order. At Dementia Australia, we work really, really hard to educate people that you can live well with dementia. That yes, there are cognitive changes, but with the appropriate supports in place, people can live meaningful, happy, and long lives despite the disease. In most cases, it isn't inherited, so because your parents had it, doesn't mean you're going to get it. The risk, or vice versa, the risk does increase with age. The symptoms are different depending on where the disease is in the brain, but also the experience is different. So two ladies of the same age living in the same town with Alzheimer's disease will experience it extremely differently, because it will depend on their life history. So you make sense of what's happening to you by what's happened to you in the past. Your mindset, how you approach it, the supports that you have around you, the way people treat you, which is why we can all learn as a community how to behave better around people with dementia. We can make a real difference to the way people experience their disease by informing ourselves and changing our behaviour. Early diagnosis, early investigation by your doctor is the best thing you can do, because you might be treating something that isn't dementia, or you might have early access to drugs that may delay the progression of the disease. So there are drugs for Alzheimer's disease. They don't cure it, but they do delay the progression. Okay? but they work in the early stages. They don't work if you rock up and you're several years into the disease. Just before we come on to questions, as I said at the beginning, Dementia Australia is funded by the National Dementia Support Programme. We are based in Perth, but from Perth we do support the whole of WA. We do a lot of work with people by phone and by video call. We do one-on-one support with a dementia support specialist. So that's talking about your personal situation, what it is that's difficult, what strategies, what education can we give you to improve life for the person with dementia and the people who are caring for them. We have 3 dementia-specific counsellors in the office in Perth. So they deal more with the emotional side of it, but their knowledge of dementia is such that they inform their practice through that. We have some support groups, and I know this afternoon we're going to talk about creating a support group in person here, but we also have some that are online. We have an abundance of information and resources. There's a lot on our table. We carried it all the way down from Perth, so please take it because I don't want to carry it all the way back. There's a lot of information on our website. We have a helpline that is open 24 hours a day, 7 days a week. You will speak to a dementia advisor right there and then. And all our information is backed by science and lived experience. So you will know that you can get on Google and you can find out all sorts of things. The miracle supplement you could be taking, or the miracle change in diet, or whatever. It's really important that whatever information you access is backed by science and it's authentic. So Dementia Australia and Alzheimer's WA as well pride themselves on providing information that is accurate. So that's just a sort of plug to be aware of where you're picking up information. And finally, Dementia Australia do a lot of advocacy work. So we have advocates who are people who've engaged in our services, either living with dementia or caring or have cared for somebody. But you'll see they're lobbying the government for changes in services, for the changes in the way communities are presented and things are understood. So we like to say that what we're doing is enabling people to live well, so that message, go home and get your affairs in order, is not one that people are hearing. But that message of, I'm going to help you live well, is what you're hearing. Okay, you're welcome to ask me any questions. Very, very common. It's really common because, as we talked about, that lack of insight. So if you don't have insight into something that's wrong, it's somebody else's fault. So we have a tendency to suggest that you would go to the GP yourself and raise your concerns.
By myself?
By yourself. So these are...
Can't go with him.
No. No, and a lot of people will also not thank you for talking about them in front of them. And we never ever want to disempower a person. We never want to point out what they can't do. We want to focus on what they can do. So we will encourage carers to go to the doctor by themselves, to list their concerns, to list their evidence. So these are the things I've noticed. And then ask the doctor for help. That's when that sort of routine phone call comes in. You know, or I'm doing some routine health checks. Can you come down and have your blood pressure taken or a blood test or whatever? And as part of that, the doctor can do some investigation without them knowing that it was initiated by you. Does that make sense? Sounds a bit sneaky, but it's much better that way than you drag somebody unwilling and you point out all their deficits in front of them. Yeah, because you've got to look after your brain the same way as you look after your body. So we know that, heart disease did a lot of information around awareness raising about keeping active, eating a good diet, those kind of things. I've got a nice book. Oh, here comes Jane. So it's called Healthy Brain, Healthy Life. You've got to exercise your brain the same way as you exercise your body. So cognitive exercises like crosswords, like Sudoku, like word puzzles, creative activities, so arts and crafts. The biggest one is socializing, so interacting with other people, talking to other people, going out, being involved, coming down here and joining activities, whatever they may be, arty, music, exercise classes. Yeah, so absolutely. Keep doing things. Grief and, particularly the change in lifestyle after like 60 years together is massive. So it would be normal that you would change in the way you think and the way you act. And that is at the forefront of your mind. So yes, it is. I would say that it's worth talking it through with a doctor. But it's also, everybody's memory declines as we get older. And I had a client once who explained it to me beautifully. Or he walked with a stick. He said, I walk with a stick because I've got a gammy knee, and if I don't use my walking stick, I can't walk well. He said, so there's nothing wrong with my wife's knees, but she doesn't think like she used to. But if we could give her a walking stick for the brain, she would function just the same. So we've got a lot of ideas, and I'm happy to talk to you afterwards, about little walking sticks we can put in place for the brain, so that, what can I do so I don't forget, or so I remember what day it is. It doesn't mean that it's dementia. It means there's other things going on, but we can help support it. Does that make sense? Yeah. And I'm really pleased to hear the way you said that. We've both been going, because I've heard too many times people say, oh, yeah, well, my husband goes to a speech pathologist for an hour a week, but it's not changing. Well, it's not changing because you're not practicing. You're not learning those strategies and using them. So a lot of what we do and a lot of what allied health therapists do is helping a carer learn how to adapt the way they live as well, in order to help the person with the disease. I wish we did, and the only answer I have for that is that there are millions of dollars being spent worldwide to work out what's causing those amyloid plaques to accumulate. Because if we could stop them accumulating, we could stop the disease.
So it's not fluoride or sugar or the food we eat or
so we
how
don't
we
know.
eat it?
No, we don't know what it is.
Why not? What century are we in? How long have we been practicing this probable?
Yeah, great question. But there are people working on it.
About time.
And I do fundamentally believe that one day we will know.
Oh, might be a bit late for me.
I guess, as you were saying, Louise, as Louise was saying right at the beginning, that as we're ageing more due to medical intervention, then there's more of a chance of that happening.
Yeah.
And we are living a lot longer. I think I said last year at the Expo, we had a thing of a time walk here where you could walk along where you were aged. We did it here, and you put yourself in the place where you are now, and then you go back and stand where you think you feel like, you know. And I did some research on that and looked up. My dad used to say a use-by date, but what's the proper word for it? A life expectancy date. I was born in 1953. On that year, I was expected to live until 72. Now, which isn't that far more, it's 85 for women. You know, really, we expect a lot. You know, we expect a lot. So we've got to do, if we're going to live longer, we've got to put the effort into staying well and doing all the things that Louise is telling. Anyway, I'm taking over your...
That's the example that was given earlier, right? Like, we maintain a car, we take a car for a service, so we've got to look after our bodies and our brains as well, because they do have a use-by date. Way too often, people who are living with dementia withdraw socially because they're embarrassed, because they don't think that they can do the things that they used to do, or their carers are embarrassed and they don't want people to see them like that. That's actually the worst thing that can possibly happen. So we want people to stay engaged, and a large part of what we're doing, and Jane is running a session at the Civic Centre on Monday afternoon, is if we can make the community aware and the community more accepting, people won't withdraw and they will have a better quality of life.
Thank you. So we all need to join CNC.
That's right. That's right.
Louise, is Jane going to speak about what she's doing on Monday night, or are you going to speak about that?
Okay, so we are here until Tuesday. On Monday morning, I'm running a session here which focuses on changes in behaviour. So why a person living with dementia's behaviour changes, what strategies we can put in place to cope with those changes of behaviour and to make their life and a carer's life better. So that's Monday morning. Monday afternoon, 5:30 at the Civic Centre, Jane is running a session called It Starts With You. So that's about how everybody's awareness can be built into what dementia is, what challenges a person living with dementia faces, and how as a community we can wrap our arms around them and then we can make life easier. And then on Tuesday morning, I'm running here a session called Activities at Home, which looks at activities that a person with dementia can do, how activities can be modified so that a person is not withdrawing, is not sitting in a chair looking at a blank wall, but is living a purposeful and meaningful life. And although it's called Activities at Home, it's actually activities in general. So we know, we've talked about that apathy, that lack of motivation. So this is how we can combat those. We're also here all day tomorrow. If anybody would like to meet us, one-to-one, just discuss anything, any questions about dementia or supports or services. An activity is anything we do. So yes, it can be puzzles, it can be exercise, it can be learning a new hobby, it can be doing the household chores, it can be baking, it can be cooking, it can be dressing, all those things. Okay. So my mum always told me that fish was brain food. Yeah. I don't know if that's true or if that was just to get me to eat fish. Well, the phrase we use is anything that's good for the heart is good for the brain. So we know that a heart-healthy diet, so a reduction in saturated fats predominantly, is good for the brain because it's keeping that flow of oxygenated blood. I'm not a nutritionist. I'm not a doctor. I firmly believe that everything in moderation is the phrase my grandma used to use. I don't think there's a lot of benefit in denying yourself anything. Excess alcohol is not good for you. Excess sugar is not good for you. Excess fat is not good for you. But a little bit is all right. Does that answer your question?
Thank you, Louise.
Okay, thank you.
Very much.
So my name is Steph Della Cuesta. I'm one of the solicitors at the Goldfields Community Legal Centre. So a little bit about me and my background. I used to work for a law firm in Perth where we specialise in deceased estates. So I suppose all the weird and wonderful, lovely things that happens after someone's died and happens when people are grieving. I suppose I've seen lots of things, not wonderful things. So I've seen a lot of the other side of what happens. So I'm encouraging everyone now to please have some form of a will. So a will, why you should have a legally valid will. It ensures you have peace of mind in knowing that people who you choose to benefit from your estate will be the people who receive your estate. So you get to choose who your executor is. Hopefully it's someone that you trust to distribute, follow your wishes, things like that. This person is obviously going to know the ins and outs of everything that you had in your life as well, so just keep that in mind. You also get to choose your funeral wishes, so whether you'd be cremated or buried and if you'd want your organs donated. Please keep in mind that sometimes the will isn't found until after all the funeral things have happened. So we also say that funeral wishes, please let your friends and family and whoever else know what your wishes are for your remains, because sometimes the will is found after the fact. You also get to choose who receives your gifts, so any specific gifts that you may have. I know in my family we have a weird obsession with fancy dinner sets that my great-grandparents brought over from England, so we fortunately get all these wonderful dinner sets that are in a lovely cabinet at the moment. Any other gifts that you may have, that includes jewellery, anything that you want to specifically go to a particular person, these are the things that you get to choose in your will. And if people have any minors, children under 18, they also get to choose who may be the guardian of those children if they are the sole parent when the person's passed away. You can also choose who obviously gets different portions of your estate. So I know I've spoken to a few ladies around this morning and the other night that sometimes they think one child might need more help than the other. So in your will you get to choose these portions of how much everyone gets or what percentage everyone gets as well. So back to your executor. So they are the person named in the will that carry out your wishes after you've passed away. They organise and collect the assets, all of your assets and your debts, and distribute the property as set out in your will. If you pass away without a will, that means that you have passed away intestate. And if you pass away intestate, your estate is distributed in accordance with this lovely piece of legislation called the Administration Act. So you don't get to choose who your administrator is or how your estate is left. The Administration Act basically sets out every scenario, so who you're survived by, whether it may be a spouse, whether it may be children, if you don't have a spouse and children, whether it may be siblings or parents or nieces and nephews. So the Act sets out for pretty much most scenarios, and that's how your estate will be divided if you don't have a will. It's all set out in this lovely piece of legislation. can your will or estate be contested? Yes, it can, but not by everyone. So there's another lovely piece of legislation called the Family Provision Act. That gives us a list of eligible people who may be eligible to contest your estate. If they're not within those realms, then they can't contest. So one example I like to use is estranged children. People think, oh, I haven't spoken to them for 20 years, they don't need anything from me. Once someone has died, people come out of the woodwork. You would be amazed. So just keep that in mind. But when you have a will drafted, these are all the things that your lawyer should be able to tell you, and you should be advised at the time. So about who may be eligible to contest your will, executor's duties, what might happen, your funeral wishes. These are all the things that you get advised on when a will is drafted. If you don't have a will, you probably won't get this advice. And then if you've passed away intestate, your choices and your wishes, they don't get noticed. So keeping that in mind. So everyone please think about a will at least, even if you're jotting down some ideas. At the Goldfields Community Legal Centre, we can help draft with wills, enduring a power of attorneys and enduring power of guardianships. Even if you're not wanting to draft one but just wanting some advice, we can help you out. I know that Mr. Gray is here around somewhere. He can also help out with the same wills and deceased estates advice. But I think that's my quick spiel for today. Did anyone have any questions?
So if you pass away in Perth, or they've got facilities to, or you're on life support, they can actually harvest your organs from that point of view, not from here, not from Esperance. So yeah, basically. And also another thing, if somebody puts in their will that they want to be donated to science, that's a whole different issue, and it depends on the University of WA whether they have a spot for your body. They can actually say, no, sorry, there's a whole pile of criteria that you have to go through, that whether they accept you or not as well. So as much as you put it in your will, it doesn't necessarily mean that it's going to happen.
They're always encouraging people to be organised.
Absolutely. That's right, yeah. So Capital City is probably the only spot. Yep, thank you.
Yeah, sorry. That was new information for me as well. I wasn't sure of the schematics of how everything worked. I just know that if you are an organ donor, it can be placed in your will, and we can have your organ donor number and everything included as well.
Just to follow up on that, we can't predict where we're going to be when we're deceased, and it may be that we are flown up to Perth or in Perth when it actually happens. So I wouldn't say don't put down an organ donor just because you feel you live in Esperance and it's not going to do anything. It would be best if you wanted to do that, definitely put it down, because you just may end up, that it works out for the hospital and works out for other people. So don't let that be a limiting factor because you live in Esperance.
I suppose expanding on that, that's also an after the fact thing as well. So make sure you let people know that you want to be an organ donor or that you want your organs donated, because sometimes if you've been buried or cremated, we can't get them back. So if you, I suppose, pass away with significant amount of assets, at least you have a house or nice lot of money in the bank. If you pass away with a will, your executor will apply for something called probate. It's an affidavit your executor has to sign. They also have to send through your death certificate to Supreme Court and give a list of your assets at the date of your assets and liabilities at the date of your passing. So for that instance, if they wanted to find out if grandma had a probate, they can apply to the Supreme Court and ask if probate was made. It just depends on what kind of assets you had. Not everyone needs a probate. Sometimes people just die with $90 in the bank. Go to the bank, everyone signs a form, consents to the money being dispersed. I had a lady the other day, the bank wouldn't give her the $90, her and her sister. the bank told her she needed to go and get a grant from the Supreme Court. To apply for the grant, it's $370. So we just sorted her out, helped out with the forms. Bank said, oh, okay, this is all she's got, this $90, sure. The 2 beneficiaries can have it, and they dispersed it. The bank's always going to tell you you need a grant. You're not always going to need a grant. So please seek some legal advice if that's what you've been told, especially if it's something like $90. But in terms of the will, unless there is a probate, all you can really do is ask the executor. But if you're not a person entitled to the information, they don't need to give it to you either. So it's all about trying to fact find on your own. No, that's fair enough. And unfortunately, it's only the executor that can give that information, and if other beneficiaries want to let everyone else know as well. But as far as a practical sense, if there was a probate, you can apply to the Supreme Court and ask or you can ring up and ask sometimes. You get a nice person on the phone and they'll tell you if probate was made. Yes, that's something that we can help out with, but if he's 17, I'll need him to come with a guardian as well. So once your will is made, you must store it in a secure place. There is something called the WA Will Bank. It's run by the public trustee. If you were to, they have a form online. You can fill it out, send it in with your will. They store it for free. If you don't want to store it there, you can store it if you have a safe at home. Private lawyers usually offer free storage or some sort of storage for your will if they've drafted it. Sometimes your accountant will, but please just make sure wherever your will is stored that your friends and family, especially your executor, know where to find it as well. But Will Bank, there should be a downloadable form. It's free to deposit your will there. To get it out, usually all the person would need is a copy of your death certificate, their ID, and they have to be the executor to be the one to get it out, not Joe Bloggs down the road. You have to be the named executor in the will. You won't get a death certificate until after there's been a funeral. It takes a few weeks. I think you guys have to sign off on that. It goes to birth, deaths and marriages, and then it will get sent. The death certificate gets sent out. So if you need probate, the executor will have to apply for probate. They will need to execute an affidavit. They'll need the original copy of your death certificate, and they'll need to give the court it's called a Rule 9B. It's a statement of assets and liabilities of everything that you owned solely in your name at the date of your passing. And that needs to be given to the Supreme Court with the $370 fee. Court then says, yeah, great, executor. Court then sends the executor back this lovely piece of parchment with a big red stamp on it and says that this person's the executor and they have the authority to act on behalf of the estate. Does that answer your question? Yeah? Yeah? So basically, if you're an executor and you get a bit stuck, please just seek some legal advice. It is a really big job. And if you haven't done it before, it's really confusing and you're not sure where to start. That's something that we can help out with. That's something a private lawyer can help out with. It's completely your preference. Usually that's the preference, especially because sometimes your executor is either your spouse or your children. Trying to think about legal things and being asked questions and being told to do things while you're grieving gets a bit hard. So I know I've had a few people in the past that their husband or wife has passed away and the children were the executors, that after that first spouse has passed away, the survivor changed their will to a friend because it was just too much on their children. So I suppose that's also something to think about when you're drafting your will as well, is whoever you make your executor has to be the person, they're the person to do everything. So they make sure the bank's closed, Centrelink payments are stopped, utilities stopped, your house is going to be sold. There are all these things that have to be done. So you just keep in mind that this person has to do all these things as well as manage all the money and give it to everyone that is entitled to it. Yes, you can have more than one executor. They can be joint or act separately. That's something that you get advice on once your will is drafted if it was done by a lawyer. Executors can be beneficiaries, yes. Normally, in the past, it's been the eldest son. I don't know if that resonates with anyone. Has been the executor, and then the son and the rest of the kids are the beneficiaries. That's a normal scenario. In terms of wills, there is homemade wills, but I very much don't like them because they come with mistakes. And when there's mistakes, it may make your will invalid, and then your estate might be subject to an intestate estate, and therefore your wishes may not be followed through. So my preference is, even if you still want to do a homemade will, I mean, a will in general is lovely, but please just seek some advice and make sure that there's no mistakes, everything's drafted correctly, just because we want your wishes to be followed through, not, you know, something's happened and then all of a sudden your will, it's invalid and it can't be followed.
We were talking about wills, and you know, quite a few people that come to the Death Cafe have had experience of not having them. And I said, why don't we get some T-shirts printed? We're all going to die. Have you made your will? Wouldn't we love? Because apparently, what's the percentage of people, Steph, who haven't done their will? And that's what we're all about here, especially at the Death Cafe, is taking control of our own end of life. And part of that is to make it easier for our children and whoever's after us, because it's so stressful for our families to come home, especially when they don't live locally, and deal with all this stuff. So that's what we're about. And part of that, you know, having a will, is also having an advanced health directive. We've got some up on the Death Cafe table there. They've brought a new form out. When was that, girls? Not last year, the year before? Anyway, if you've got an old health directive that's more than 3 years old, they still function, but these new ones are much better in that you can have much more personal input into it. The palliative care WA people printed a heap of cards, and they were called Dying to Talk cards. So the way is to spread them out, put them into sections of what's important to you, what's not important to you, so that when you're doing your health directive, you fill all that out at the beginning, what's important to you, because when you come to the second part of the form, it's going to ask you what do you consent to and what you don't consent to. So that way you can sort of say, well, I only want, for instance, hydration if I'm going to be able to see my family. They've got to come here, so only for that long, and I don't want long term. But in order for that to make sense, you have to put in the beginning of the form what your good life is. So I've done, taken the liberty of doing a list of all those little comments from their cards and from other cards that come from other organisations. So you can take one of those lists and take a form and go through it and try and get your advanced health directive done, because that's your power to make your own decisions. You don't want your kids or your family standing around your bed if you've had something go wrong, and they've got to make a decision about whether you want to be kept alive or don't. Make that decision now. When we're of sound mind, again, that's another thing. Once you're diagnosed with dementia, you can't do any paperwork like that. So make them now. They might never be used. They're only going to be used if you can't speak for yourself. But it's just a way to have that power over your own medical situation. So Meredith and I are going to be doing little short workshops. Last year in this space, 53 people came and did the workshop with Irene. Any of those people here today? Yeah. Have you filled out your Advanced Health Directive yet? So the reason is I'm asking is because Irene got from the government 53 of those packages, and they're getting a bit, mean now on handing them out. We're paying for them all, and they want people to do it online. So I have got some of the original kits up there, but I'm just asking people, when you've used them and when you've filled your form in, to bring them back so that we can share them with other people. But we can still get more, but we don't want boxes and boxes of them that are going to be sitting in somebody's cupboard. So please go up, grab a form, grab one of those sheets, and just have a look at it. You're not going to do it in 5 minutes. It's quite a process, but it's up to you to list down what your good life is, and then you can fill the form out according to that. And Meredith and I will be having a few little workshops through the year. We'll just use the lounge room just to help people work through that when it's hard to do so.
It's probably quite a good idea to let your children know why you've done what you've done, because when you've died, you can't go back and answer the questions, because sometimes with families, they're not, maybe they're not even or whatever, and families then have a big discussion, well, how come you got this and I only got this? So maybe have a discussion with your children as to let them know why you've dispersed what you've dispersed.
Yeah, that's a good idea. Yeah. And also, talking about the Advanced Health Directives, on that note, Heather, is to give your children a copy of it, because they need to know before the event what your thoughts are. We don't want them to race back to Esperance and say, oh no, we've got to save Mum. No, we don't. Mum's made this decision a long time ago. So make it your choice about what you want.